So the first case here for NF1, neurofibromatosis type 1. The first case here, as you can see on the chest X-ray, there are skin lesions here. These skin lesions is indicative of the plexiform neurofibroma. Plexiform neurofibroma of NF1. Okay. Let's see the next case. This is the next case. And this is this is an illustration of this case. Okay, so what you can see here in this case, there are two opacities. There are two opacities. The first one is seen arising from the first rib, the right first anterior rib. The second one, superior aspect, is seen arising from the right. Let's count. So this is the first rib, the second rib, the third rib, fourth, sixth, seventh rib. So the second opacity, superior aspect, is seen arising from the right seventh rib with well-defined inferior aspect or inferior margin. Okay, there is also evidence of inferior rib notching at multiple ribs, seen at multiple ribs. Evidence of inferior rib notching at multiple ribs. These lesions is not associated with rib destruction. It's not associated with rib destruction. So however, once you see inferior rib notching on the chest X-ray, you need to check for the 3 sign or figure of 3 sign of the aorta. You need to check for the mediastinum for any evidence of aortic coarctation. So let's see here. There's evidence of inferior rib notching, however, there is no evidence of figure of 3 sign of the aorta, so there is no aortic coarctation. However, the inferior rib notching here is associated with rib lesions, with opacities arising from the ribs. So this is consistent with neurofibroma of ribs. Sorry, it's not neurofibroma of ribs. This is consistent with neurofibromas. So in this case, I would recommend further assessment with a CT scan. And if this is the first presentation, I would recommend orthopedic referral for further workup of a potential neurofibromatosis type 1. So in this case, you need to have a CT scan done to confirm that these lesions are arising from the ribs and not from the lung. And if this is the first presentation of the patient and this case is not a known case of NF1, I would recommend orthopedic referral for further workup of a potential neurofibromatosis type 1. Okay, so this is the next case. There is this is a coronal T2 weighted image of the face and the neck and the chest of a child with a neck mass. And in this image, you can see that there is a large lobulated mass with serpiginous contours. A large lobulated mass with serpiginous contours located on the right side of the face, the right side of the neck, and the thorax. Okay, let's see the next image of the same case. On axial images, you can see that the mass is seen. You will just describe the mass from inside to outside, okay, on axial images. So the mass is seen intimately related to the right para and the prevertebral spaces of the cervical spine. The mass is intimately related to the right para and the prevertebral spaces of the cervical spine. At which level? At the level of the superior mediastinum. As you can see here, this is the level of the superior mediastinum and the neck level. Okay, this is the neck level. The mass is intimately related to the right pre and the paravertebral space. This is the pre and the paravertebral space. Okay, at the superior mediastinum and the neck levels. It shows extension through the intervertebral foramen, and the mass shows, this is very important, the mass shows extension through the intervertebral foramina at multiple levels. Okay, look here. This is the cord. This is the spinal cord, the cervical spinal cord. And here's the mass that causes extension through the intervertebral foramina at multiple levels. This is the extension at one level, and here's the extension at another level. After that, the mass seen insinuates through the neck spaces, the right neck spaces, insinuates through the right neck spaces to form a large superficial mass or a large superficial component. Insinuates through the neck spaces to form a large superficial component, as you can see here, with extension through the intervertebral foramina at multiple levels. So what about the next image? At the level of the superior mediastinum, the mass is seen encasing the blood vessels without invasion and with no invasion of the adjacent structures. No invasion or destruction of the adjacent structures. The mass is seen encasing everything, encasing the adjacent vessels. Okay. What about the next images? These images showing that the mass, the characteristic mass appearance on the T2 weighted images. Look carefully. The mass is heterogeneously T2 hyperintense. The mass is heterogeneously. Can you see this dark spots inside the mass? So the mass is peripherally hyperintense on T2 and centrally hypointense. This is the characteristic target sign of neurofibroma. The mass is heterogeneously T2 hyperintense, okay, with multiple internal flow voids. It's multiple internal flow voids. This is the typical appearance, okay? And it is heterogeneously enhancing in the post-contrast images. So as you can see, peripherally enhancing, central non-enhancement, also characteristic feature of neurofibroma. You can see plexiform neurofibroma, okay? So the findings represent a neurogenic neoplasm. So this neoplasm is a of neurogenic origin. A neurogenic neoplasm with no aggressive features, no invasion of the adjacent vessels or destruction of the adjacent structures. So the principal diagnosis here is plexiform neurofibroma in a 3-year-old patient with neurofibromatosis type 1. Plexiform neurofibroma is a characteristic feature of NF1. Differential diagnosis: peripheral nerve sheath, malignant tumor, or soft tissue sarcoma. Differential diagnosis of tissue sarcoma or malignant tumor of the peripheral nerve sheath. So I would alert the referring physician and recommend 3 things here. So in plexiform neurofibroma, remember you need to recommend 3 things. What's the first thing? Image guided biopsy. You need to recommend a biopsy of these lesions. Image guided biopsy for tissue diagnosis. The second thing, image surveillance. Image surveillance, as there is a risk of malignant transformation of these lesions. So you need to first diagnose by image guided biopsy. Okay, if you will leave these lesions like this, you need to image surveillance of these these lesions, as there is a risk of malignant transformation, but the mainstay treatment is with the plastic surgery. So the third thing you need to recommend is discussion at plastic surgery MDT. Discussion at plastic surgery MDT. These lesions need to be removed as there is a risk of malignant transformation. Okay, this is the next case. Another case of NF1. So this is the axial CT scans, bone window, and soft tissue window. of the brain showing there is a right-sided, there is a fusiform enlargement of the right intraorbital optic nerve. It is isodense to the contralateral optic nerve, which is normal here. Okay. There is also a right-sided protrusion. Okay. On CT scans, you need to mention that there is no tram track calcifications of the enlarged optic nerve. There is no tram track calcification here. And also there is no increased density is seen here. You need to check for the increased density here. So these images is important, both of them. Here you need to check for that there is no increased density or hyperostosis of the optic canal, of the optic nerve bony canal, And here you need to check for that there is no tram track calcifications of the enlarged optic nerve. Why? Because these two features will make the diagnosis more likely to be optic nerve sheath meningioma, which is not the case here. The case here is most likely to be optic nerve glioma, which is common with NF1, neurofibromatosis type 1. Okay, so on CT scan, you need to look at the bone density on bone window and the calcification on soft tissue window. Okay. Here, the MRI images of the same patient. Okay. There is a fusiform enlargement of the intraorbital part of the right optic nerve, and it is iso-intense to the brain parenchyma. The contralateral optic nerve is normal. It's avidly enhancing. So all of these criteria are characteristic features of optic nerve glioma. Fusiform enlargement, iso-intense. It's avidly enhancing on the post-contrast images. Okay. Here on the MRI images, you need to check for that there is no intracranial extension of these tumors, of this mass. There is no intracranial extension. There is no intracranial extension as seen here. There is intracranial extension into the optic chiasm and optic nerve pathway, because this will make the diagnosis more likely to be optic pathway glioma. And this case is not optic pathway glioma. This case is optic nerve glioma, localized to the right optic nerve. Okay. So you need to comment here, there is no other masses seen in the optic chiasm, or along the optic nerve pathway. Okay, so this is not optic pathway glioma. Also, you need to comment on the brain parenchyma. Why? Because in neurofibromatosis type 1, there is common lesions seen in the brain parenchyma. You can find sometimes foci of abnormal signal in the basal ganglia and in the thalami. at the level of the basal ganglia and thalami. So you need to comment that there is no focal abnormal signal at the level of the basal ganglia or the thalami. So there are no features of an F1 of the brain parenchyma. Okay, so the findings in this case represent a neurogenic neoplasm, also neurogenic. It arises from the optic nerve, neurogenic neoplasm arising from the right optic nerve with no aggressive features. Okay, the most likely diagnosis is right optic nerve glioma in a 7-year-old female that caused decreased vision in the right eye. And this right optic nerve glioma, this is an isolated finding and is not associated with other features to suggest neurofibromatosis, that it is a part of neurofibromatosis type 1. So you need to mention that. Diagnosis is right optic nerve glioma. And it seems that it is an isolated finding and and there is no other features to suggest that it is a part of NF1, neurofibromatosis type 1. Okay, so I would recommend referral for discussion at neurosurgery MDT for possibility of debulking surgery. The mainstay treatment for optic nerve glioma is debulking surgery, as this tumor is affecting the right optic nerve, so it needs to be debulked. Debulking surgery, okay. As I mentioned, this case is suffering from decreased vision, so this needs to be removed. Next case of NF1. Sagittal T2 and T1 weighted images of the thoracic spine showing that there is smooth, continuous, posterior scalloping of multiple vertebral bodies at the mid-thoracic level. This posterior scalloping is caused by the associated expansion of the dural sac, and the enlarged subarachnoid space. And you need to mention that the spinal cord is normal with no evidence of a spinal cord tumor. Okay, so why you need to mention that? Because these features are posterior scalloping of the vertebral bodies caused by dural ectasia. And dural ectasia is a characteristic finding, a characteristic sign of NF1. However, spinal cord neurofibroma is a sign of NF2. So that's why you need to mention that the cord is normal with no cord tumors. Okay. Here, there is thinning of the pedicles at these levels, at the mid-thoracic level. There is thinning of the pedicles. As you can see here, this is the normal pedicle. This is the normal pedicle. This is the normal pedicle. Here, the pedicle starts to be very thin. There is thinning of the pedicles at these levels by what? By the enlarged neural foramina. The thinning is caused by the enlarged neural foramina, and the enlarged neural foramina is caused by the associated protrusion of CSF filled expanded spinal meninges. CSF filled expanded spinal meninges. So, how to comment? There is thinning of the pedicles, and the thinning is caused by enlargement of the neural foramen, and the enlargement of the neural foramen is caused by protrusion of CSF filled expanded spinal meninges. Here, there is posterior vertebral scalloping. It's caused by the enlarged or the expanded dural sac, and the expanded dural sac is caused by the enlargement of the subarachnoid space. This also forms a left-sided CSF-filled meningeal sac at one level. It's called lateral meningocele formation. Lateral meningocele formation. Lateral meningocele formation is typically seen with an F1, and it's not typically seen with Marfan and Ehlers-Danlos syndrome. So the findings represent dural ectasia with a lateral meningocele formation, and these two features are consistent with the diagnosis of NF1 and the differential Marfan and Ehlers-Danlos syndrome, not typically associated with lateral meningoceles. This case would be most likely a known case of NF1. So I would recommend surveillance imaging to detect the complications of NF1. The mainstay treatment here, or the main aim of the treatment here, is not to diagnose NF1, as this case is most probably a known case of NF1. Okay, what is the aim of the management here? The aim of the management here is to detect the complications of the already known NF1 by surveillance imaging. Surveillance imaging. That's it. Thank you.